So, this will be discussed under the following headings. Number one is definition, then what are the types of ectopic pregnancies, then is the pathology, what happens if the pregnancy is implanted outside the normal site of implantation, and then presentation, what will be the clinical picture. So, how could you suspect that patient is suffering from abnormal pregnancy, that is gestation outside the uterus. Then what are the investigations to be done and to diagnose the condition for confirmation of diagnosis. Then what are the other diseases which will be confused with the ectopic pregnancy, that means differential diagnosis, and how will you manage the case. So, these are the headings under which this topic will be discussed. You know, the complications in early pregnancy, usually whenever the pregnancy is disturbed at the early period, it will be manifested by bleeding. So, bleeding in early pregnancy is the bleeding in late pregnancy separate. So, come in. Bleeding in early pregnancy is a symptom. So, patient will present with that. So, lot of complications may give rise to bleeding. So, number one is abortion, that means interruption or disturbance of pregnancy. Possibly this class is over, that has been discussed in the previous classes. Next is ectopic pregnancy, which is the discussion today, and another class is hereditary mold, which is actually no pregnancy. So, that will be discussed in the next class. So, these are the three important complications which has got the similarities in presentation. So, these are very important to differentiate because treatment differs. So, very important to differentiate, to diagnose among these three. See, this is the fallopian tube. This is the fallopian tube where there is a pregnancy. So, and this is the uterus. So, it is outside the normal area of location of the implantation. So, within the tube, which is the commonest site for ectopic pregnancy. So, this is a picture of fertilized ovum is implanted and develops outside the normal uterine cavity. So, that is by definition is ectopic pregnancy. So, implantation outside the body of uterine cavity, even if it is at the cornu, that will be ectopic pregnancy. So, that is the normal site of implantation is uterine cavity. Then the types, if you consider what are the sites where this implantation can occur, because the trophoblast has the capacity to invade the tissues. So, wherever these immature cells are present, they will invade the tissue and the trophoblast will grow and fetus may grow or may not grow. If the sufficient vascular supply is not there, it will not grow, the fetus may die. So, tubal pregnancy is 95%. Among the tubes, there is ampulla, which is the common area of implantation. Then is the isthmus, maybe at the femora also, and then at the interstitial part of the tube. These are the four sites where the tubal pregnancy can occur. So, commonest is the isthmus, and 95% cases is the tubal. Then it may be ovarian. That means at the after ovulation, the conception occurs at the site of ovary. So, usually the fertilization occurs at the ampulla. So, here the fertilization occurs on the ovary. So, pregnancy grows within the ovarian tissue, that will be called ovarian pregnancy. Then in the cervix, if the fertilized ovum descends down into the cervical canal, it will be called cervical pregnancy. Then cornual pregnancy may be there. A cornual does not mean one cornu. So cornu there is interstitial part of the tube. So that will be called interstitial pregnancy. But when it is implanted and grows in the blind horn of a cornu, so that it is a developmental defect where one cornu does not communicate with the uterine cavity. So possibly the ovum from the other side migrate there from the not the migrate. So ovum and the sperm goes to the other side and fertilization occurs at the ampulla and it is implanted into the blind horn. So not communication with the uterine cavity. That is called cornual pregnancy. Pictures are there but not here. Then it is maybe abdominal. So following fertilization, it may be extruded into the abdominal cavity through the tube, through the fallopian end, or following rupture of the tube, that is called abdominal pregnancy. That will be called secondary abdominal. A primary abdominal is much less rare, but secondary abdominal can occur. The implanted ovum which is extruded from the tube, if it remains alive, so it will be it will grow in abdomen or in the vital organ, that is called abdominal pregnancy. Scar pregnancy, that means caesarean section scar. So if the pregnancy is implanted over the caesarean section scar, the myometrium there is very, very thin, so it could cause complication. It will not grow like normal pregnancy, so that will be called scar pregnancy. That is a very new entity because of the rise of caesarean section, so this is occurring. They are the types. So this picture shows that this is 12% is isthmic and 2 to 3% is here, that is interstitial, and so that will be confused with the whether it is at the angular or the interstitial. So it will be called interstitial, and then it is at the ampulla. So following fertilization here, so there is not, the fertilized ovum is not transported along the tube, so it grows there. So that is 70% occurs the ampullary pregnancy, maybe at the fimbria, and the ovarian is 3%, and cervical occurs less than 1%, the cervix, and caesarean section scar also at the less than 1%, and so abdominal is 1%. So secondary abdominal likely. So this picture shows the incidence of different sites of ectopic pregnancy. So what the pathological things which occurs following implantation outside the uterus. So outside the uterus, the submucosa is not there, so there will be no decidua, so implantation will not be proper. So the chorionic tissue or trophoblast can easily invade the underlying muscle tissue. So it will distend the muscular layer. So, and because there is no decidua, so nutrition is lacking, so there may be death of the conceptus at the very early period. And not only that, there will be bleeding at the choriodecidual space, and so bleeding, so conceptus is surrounded by blood and the conceptus is dead, so it is nothing but a mass, so that is called tubal mole. A mass surrounded by fertilized egg, surrounded by blood is called tubal mole. So dead conceptus with the surrounded blood within the tube is called tubal mole. That is one of the fate of ectopic pregnancy. Then it may be extruded through the fimbrial end, which is called tubal abortion. So one of the fate of the tubal pregnancy is tubal mole. Next, if it is extruded by the tubal motility, by the tubal peristalsis within the abdomen, that will be called tubal abortion. And this tubal abortion, if the fetus is alive, so it will cause implantation in peritoneal cavity, and that will be called secondary abdominal pregnancy, and within the tube, because of the growth of the fetus, if it is not dead, so if the chorionic tissue grows and it penetrates the muscle layer, penetrates the muscle layer leading to rupture of the tube and distension of the tube and rupture, so lack of space is there, so distension rupture. So tubal rupture is another fate of ectopic pregnancy. Definitely rupture will be followed by severe bleeding. So intraperitoneal bleeding will be there. So tubal mole, tubal abortion, tubal rupture, intra-abdominal bleeding will be there because of this abortion, and during abortion also will be bleeding, rupture will also bleeding, and implantation in peritoneal cavity. And if the rupture occurs through the broad ligament, there will be interligamentary pregnancy. So this sort of pathological things may occur in cases of tubal pregnancy. So these are the fates of tubal pregnancy. And because from this pathology, we can, so what happens to the uterus? So that is in the tube, so that is happening in the tube. But what happens to the uterus? Definitely uterus is enlarged, not because of the conceptus, but because of the hormonal changes from the trophoblast, and endometrium will show the hyperplasia of the endometrium because of the estrogen progesterone. That is called area stellar reaction. That is nothing but adenomatous hyperplasia of the endometrial lining. So area stellar reaction, and there will be no villi. So if you suspect that it is due to pregnancy, you have to go for the biopsy or histopathology of the endometrium. If you show there is no villi, that means there was no pregnancy. So that is to differentiate, which will be it will be helpful later on to differentiate between the abortion and the ectopic abortion and the tubal pregnancy. So no villi will be there. And decidual cast, this proliferated hyperplastic decidua, a time will come because of the withdrawal of estrogen progesterone, because the trophoblast is not growing, so withdrawal of estrogen and progesterone will lead to sloughing of the whole of the lining of the endometrium. That is called decidual cast. Decidual cast, that will be the shape of the uterus, that is triangular in shape. So that will be decidual cast. These are the changes which occurs in the uterus. Now, why the ectopic pregnancy occurs? Definitely because it is implanted in the tubes, definitely there is fault in the transport of the fertilized ovum from the fallopian, from the ampulla to the uterine cavity. So that may happen due to pelvic inflammatory disease. You know, pelvic inflammatory disease due to some organisms which usually causes bilateral damage of the tube and especially the ciliary function. So loss of cilia, and because of the perisalpingitis, it will cause impaired motility. So because of this loss of cilia, because of the impaired motility, so both these factors causes the lack of transport of the fertilized ovum from the tube to the uterus. So that will lead to ectopic pregnancy. So tubal surgery. So if we do some tubal surgery, means anastomosis or like even that tubal ligation can lead to narrowing of the tube and will cause ectopic pregnancy. Laparotomy in any form, suppose cesarean section or for any other regions, if following appendicitis, appendicectomy or any laparotomy can lead to peritubal adhesion and leading to impaired motility and ectopic pregnancy. And IUCD intrauterine contraceptive device, which is introduced into the uterine cavity, that can prevent uterine pregnancy but cannot prevent extrauterine pregnancy. So uterine pregnancy is prevented, but extrauterine pregnancy is not prevented. On the other hand, because of the IUCD, there is chance of pelvic infection leading to the loss of cilia and leading to increased rate of ectopic pregnancy. So, pregnancy as such is prevented by the IUCD, but rise of ectopic pregnancy following IUCD insertion. Then how it presented to us? How the ectopic pregnancy, pregnancy will be there, and because of the early pregnancy, so just delaying of the period. So somebody may not think that she is pregnant, but there is 2, 3, 4 or 1 week delay. She may assume that she will have the period within 2 to 3 days. So, amenorrhea is a very short, and because the pregnancy presentation, because there is amenorrhea may not be so long, but usual presentation is bleeding privy. So always you have to think of ectopic pregnancy in any case of pregnancy or irregular bleeding privy with pain abdomen. So that means always whenever there is acute abdominal pain and bleeding privy, always you have to think of ectopic pregnancy. That is called ectopic minded. You have to be ectopic minded, otherwise you may miss the diagnosis. Because the presentation we will discuss will be more or less same, pain, bleeding, amenorrhea, like that. So always you have to keep the ectopic pregnancy in your mind, and always we have to try to exclude ectopic pregnancy. So presentation may either of these three. It may be acute, that means because of the rupture likely, leading to acute bleeding and manifestations of bleeding like pallor and hypotension, like that. It may be subacute, means bleeding, small bleeding within the abdomen. So there is not acute picture, but patient is having bleeding and pain abdomen for few days. So that is subacute. There is hemodynamically there is not acute change. So that is subacute presentation, or you may say it is a chronic ectopic. And unruptured. So unruptured usually is discovered during our routine ultrasonography in early pregnancy. So that is one of the reasons for doing ultrasonography in early pregnancy. So you can exclude ectopic pregnancy. If you find a pregnancy within the uterus, that means ectopic pregnancy is excluded, especially where there is history of ectopic pregnancy. So there is history of ectopic pregnancy, chance of ectopics is more. So in that case, if you go USG, you can pick up these cases of tubal pregnancy before there is rupture or before there is abortion. So that will be presented by unruptured ectopic pregnancy. So clinical picture, as I have already mentioned, pain abdomen, bleeding PV and amenorrhea. They are the triad of ectopic pregnancy. See, this abdominal bleeding PV, pain and amenorrhea, that can occur in all these cases. May occur in hydatidiform mole, may occur in abortion, simple abortion. So picture is more or less same. So by the clinical picture, you may not be able to differentiate between the ectopic and other causes. So shock is a very classical picture. So shock, that means bleeding, intraperitoneal bleeding. That means shock is out of proportion to the bleeding. If you ask the patient will say bleeding is not much, but you find that pallor is much and blood pressure is very much low. So disproportionate pallor or disproportionate hypotension in relation to bleeding. So much hypotension amenorrhea than the blood loss. So that contrasts to usual abortion where there will be much bleeding plus less hypotension and much bleeding, and then there will be much pallor. But in ectopic pregnancy, out of proportion of bleeding, there will be hypotension and pallor. So that is the distinguishing picture. Then para-abdominal examination, so tenderness plus. So much of tenderness, rebound tenderness from your surgery, that patient will just will be jumping, because when you try to palpate the abdomen, so very acute tenderness because of the hemoperitoneum. So that does not, if you do not find it during abortion or during molar pregnancy. That is a very distinguishing picture. And abdomen distended, if there is much blood, much bleeding, or even without much bleeding, abdominal distensions because of the hemoperitoneum, that means peritonitis. And now on paravaginal examination, though it is very tender, but if she allows to do paravaginal examination, often she does not allow, so there will be adnexal mass. So in cases of chronic pregnancy, this adnexal mass may be felt through the fornix and very much tender. And POD, if you are lucky to feel the POD, there will be fullness, the bulging of POD because of blood clot. So clinically, if tenderness is not much, but these findings, you can suggest that possibly this is a adnexal tender mass, and especially in chronic cases and POD is full, you can suspect ectopic pregnancy. Then come to the subacute presentation. So this is amenorrhea or delayed period, not exactly amenorrhea. Amenorrhea usually, unless the second period is missed, we cannot call it amenorrhea, but there is delayed period by 7 days, 10 days or 2 weeks like that. So irregular bleeding per vagina. So following missing of period, there is irregular bleeding per vagina and pain abdomen, of course, and pallor is marked. Pallor is marked because of this bleeding inside. So pallor is marked, and PV adnexal mass you may find. And here, though you may not get that fullness and that tender mass, but cervical motion tenderness. If you try to move the cervix, patient will feel much pain because of the pelvic peritonitis, because of the hemoperitoneum. So because of the pelvic peritonitis due to blood, cervical motion tenderness will be there. So that is a picture in subacute ectopic. Patient is coming, not so much of hypertension, patient is able to move, but she will have some dizziness. So because of the presentation with the irregular bleeding PV, the amenorrhea, she may not be able to remember the exact date of period. So pregnancy test must. Pregnancy test is a must in all cases of irregular bleeding PV. So even in gynecological bleeding, whenever we find irregular bleeding PV, so that may be due to a menstrual irregularities, but in all cases we will start to proceed after exclusion of ectopic pregnancy. So we are always ectopic minded. Then come to the unruptured. That means it is picked up incidentally during the ultrasonographic examination, especially if you do TVS, so adnexal mass. So within the tube, in one of the tube, you may find a mass, and if you are lucky, that mass, the fetus may be detected, and with the Doppler, we can find that very much vascular, that area is very much vascular. Around a mass, there is vascular area by Doppler USG. So that in that way, it is detected that it may be ectopic pregnancy, and examination in case of unruptured or undisturbed ectopic pregnancy is normal. So don't find anything other than this mass by USG, and pregnancy test is positive. So pregnancy test is positive and uterus is empty and there is a adnexal mass. That means urine positive and USG negative, but USG positive with the adnexal mass. So that is the finding in case that may be a presentation or diagnosis of ectopic pregnancy. Then investigations. What are the investigations we will go for where we suspect ectopic pregnancy? Always we start with the pregnancy test. Irregular bleeding PV, we go for pregnancy test. Is it positive or negative? If it is positive, then we suspect ectopic. If it is negative, it may not be ectopic, but may be ectopic also. But usually 98% cases pregnancy test is positive, because nowadays the pregnancy test is very much sensitive. Even if you still suspect pregnancy, you can go for serum beta HCG estimation. So if that is above the normal level, then you suspect pregnancy somewhere in the body. So urine test is very, very important in case of, and easily done. Whenever the patient is entering our emergency, we can easily do it. So pregnancy test is positive. Ultrasonography reveals no pregnancy within the uterus, that is USG negative. So even the ultrasonography may not detect any mass within the tube or in the adnexal, but it can exclude intrauterine pregnancy. So that is the number 2 investigations. And USG may find adnexal mass and fetus outside the uterus, and ring of fire by Doppler USG because of the vascularity by Doppler USG, and collection. So if it is a disturbed ectopic, so there will be collection. If it is a tubal abortion, there will be collection in POD. If it is tubal rupture, there is much collection in POD. So collection and POD always favors ectopic where this collection comes. So usually it shows, it suspects that always it is ectopic pregnancy. And because of the blood and all those things, they are very difficult to get the adnexal mass and fetus by USG. So collection in POD is very much suspicious of ectopic pregnancy. Serum beta HCG. You see, wherever you are suspecting if the urine is negative, serum beta HCG could be done. Especially, it is important even after the pregnancy is diagnosed by urinary pregnancy, still serum beta HCG is to be done for planning, which will be discussed our next slides, in the next slides. So serum beta HCG is for planning of management, planning of treatment of ectopic pregnancy. And chondrosynthesis, that means hemoperitoneum, so blood within the pouch of Douglas, if it is detected by USG, it can be punctured through the posterior fornix, pouch of Douglas, it can be punctured by 18 gauge needle. If the blood is detected, that means from where the blood is coming, most likely diagnosis is ectopic. It may be due to corpus luteum cyst rupture, so it may be due to splenic rupture or anything else, but this is very important, the hemoperitoneum. If it is, especially if it is urine positive, then it dictates where the sophisticated investigations are not there. So USG is not there. There you can do chondrosynthesis, very easy procedure, needling through the pouch of Douglas. If blood is revealed, that signifies that possibly you are dealing with ectopic pregnancy. So another investigation is laparoscopy. So directly you can visualize that there is a blood within the peritoneal cavity. You may be lucky to visualize the tube which is distended because of the fertilized ovum, fertilized egg, so implantation, or you may be able to diagnose that there is damage to the tube if there is tubal rupture. So laparoscopy can diagnose, as well as after diagnosis at the same sitting, you can treat laparoscopically the ectopic pregnancy. We can come into that later on. Blood diagnosis, wherever it is, you are in doubt, you can go for laparoscopy, and by laparoscopy, of course, the patient must be hemodynamically stable. So, if the patient is in acute hypotension or acute pallor, in that case patient is not fit for laparoscopy. So, hemodynamically stable patient, we can go for laparoscopy and can diagnose the condition that is less invasive. So, instead of laparotomy, previously when laparoscopy was not there, we used to do laparotomy in case of suspected ectopic, and even if it is a negative laparotomy, that had a value because you are saving the patient. So, if you, without confirming the diagnosis, if you leave the patient, next time the patient when he will come in such a shock that you will not be able to save the patients. So, laparotomy was once a time a procedure to exclude ectopic pregnancy, but nowadays because of our so much of investigations like TVS, transvaginal sonography and laparoscopy, we can easily diagnose the ectopic pregnancy. Not only that, if there is corpus luteum rupture, that is also diagnosed from, and if the ovarian pregnancy, that can be diagnosed by laparoscopy. So, laparoscopy is very much useful in hemodynamically stable patient. So, this is the picture of laparoscope. You see, this is the uterus and this is the tube. You see, tube is there and this pouch of behind the uterus, this pouch of Douglas, no, this is the uterus, labeled is uterus, and this is the tube and this is the fimbrial end of the tube. Fimbrial end, here there is ectopic pregnancy and there is bleeding, a clotted hemorrhage, blood, and so that is tubal abortion, not rupture, tubal abortion, and so that is right fallopian tube that they have labeled. So, ectopic pregnancy less than 5 weeks gestation, so early, so there is not rupture yet, but because of hemorrhage due to tubal abortion, there is bleeding, and this is the uterus. So, laparoscopically beautifully you can diagnose and treat. So, you can take the clots by suction, by laparoscopic suction, and you can treat this ectopic pregnancy by removal of the tube or removal. We are coming to that later on. So, what about the differential diagnosis? So long we are talking about what are the other possibilities we have to keep in mind. So, always you are ectopic minded, but other possibilities are abortion. So, we have already mentioned in abortion the shock will not be much and pallor will be proportionate to the blood loss and abdominal signs will be lacking. Abdomen will not be so much of tender. Patient will allow you to examine the abdomen. Then it is pregnancy test will be positive in this case. Acute PID. So, if there is pelvic infection, in that case also patient will be coming with acute pain, but in that case pallor will be missing, and not only that, pregnancy test will be negative. So, by the pregnancy test you can exclude the PID or ectopic pregnancy, and twisted ovarian cyst, of course in this case pregnancy test will be negative, and ovarian cyst will be detected by ultrasonography, and pallor will not be there. So, from your clinical knowledge you will be able to reach a near diagnosis of ectopic pregnancy or ovarian cyst or like that. Ovarian cyst can be palpated, so that will be detected as adnexal mass. You may think that is ectopic mass, but other signs of ectopic, the abdominal signs will be there, but pregnancy test in all these cases will be negative. That is very important, pregnancy test. If necessary, you can send the blood for serum beta HCG. So, twisted ovarian cyst is another complication which needs urgent treatment. So, ectopic pregnancy needs urgent treatment. So, by laparoscopy, if you put a laparoscope, you will be able to diagnose twisted ovarian cyst or not, or it is ectopic pregnancy. So, can be easily diagnosed. So much is the importance of laparoscopy in emergency. And emergency, of course, the expertise may not be available for laparoscopy. So, that is a problem. Ruptured corpus luteal cyst. So that can also happen. There will be bleeding, there will be pain. So hemoperitoneum is there. So all are the similarities of ectopic pregnancies, but pregnancy test, beta hCG test will be negative. So that is ruptured corpus luteal cyst. Definitely laparoscopy can easily exclude. Then appendicitis, very, very important. The young woman if comes with the pain abdomen. So appendicitis, the main picture you know, it will be right-sided pain, not on the other side unless it is complicated. Pregnancy test definitely will be negative. So patient will be often, because of the acute abdomen, patient will attend the surgical department, but they may call us, they may refer us to the gynecologist for excluding ectopic pregnancy if the ectopic pregnancy is there in their mind before going for laparotomy for acute appendicitis. So pallor will be missing also, but abdominal signs will be there. So by your clinical acumen, clinical knowledge, you will be able to reach a clinical diagnosis, and that will be confirmed by our investigations like USG, laparoscope. So laparoscope not only can diagnose appendicitis, but also can operate for the appendicectomy. So can go for appendicectomy. So that is so much important is laparoscopy in a case of acute abdomen. So treatment. So after by the investigations you are able to reach a diagnosis of ectopic pregnancy, or if you are in doubt, you are planning for laparoscopy for clearing the diagnosis. So what treatment could be done? So it may be surgical, it may be medical, that means some drugs, it may be just observation. So depending upon the picture, depending upon the complications, so we can choose either of these three that you have to assess. That is our duty. So laparotomy, if somebody does a laparotomy in a patient of shock and too much pallor, there is no fault. Even if you find there is no ectopic, but you know that you are diagnosing something. So even there is splenic rupture, even there is corpus luteum rupture, all can be tackled by laparotomy, where in acute cases where the patient's condition does not permit laparoscopy, so laparotomy is the answer. So quick in and quick out, because from the injured site the blood loss is going on and there is hypotension. Because of hypotension there is less amount of blood loss. Whenever you try to rise the BP, to increase the BP by blood transfusion, that blood will again be drained into the peritoneal cavity. So unless you stop the bleeding from the injured site, from the rupture site, you cannot improve the condition of the patient, general condition of the patient. So quick in and quick out, and always midline incision. You know, midline is very quick. Just you are cutting the rectus abdominis, rectus sheath, and you can easily split the rectus muscle and go to the cavity within 2 or 3 minutes. You can reach the peritoneal cavity, and you, after opening the abdomen, you just put your hand to reach the uterus, hold the uterus out, and to see which tube is affected. So you have to locate which tube, from which tube there is bleeding. So you have to clamp that part of the tube. So once you have clamped that part of the tube, then the further blood loss is prevented. Then you give blood transfusion, then only patient condition could improve. Otherwise, without clamping, if you go on giving blood and blood and blood, so there will be hemoperitoneum, distension will go more and more. So quick in and quick out. So if you lose, because the general condition of the patient is poor, if you take much time, the patient will have cardiac arrest, because patient is under anesthesia, because of hypoxia. So midline incision, quick in, quick out, and blood transfusion after clamping at the cornu. So there is much blood loss from the uterine supply. So tube is supplied from the two sides. One is ovarian supply and from the medial side is uterine supply. So that side is more bleeding from the uterine artery. So both the side you have to clamp, but first clamp will be given on the at the corner. That picture will show it. Though the name of the surgery is salpingectomy, means removal of tube. You have to remove the affected tube to stop the bleeding, number one. Number two, if you leave the tube, there is other problems, we will come to later on that. So salpingectomy is the treatment if the other tube is healthy, because the PID is the cause. So one side there is ectopic. If you find that the other side is also damaged, so chance of further pregnancy will be very poor. In that case, we'll try to preserve the affected tube also. Salpingectomy where the other tube is healthy. If the other tube is unhealthy or lost because of the previous disease, so in that case, you the tube, we will try to preserve the tube. That is the conservative surgery. That is a conservative surgery. So not salpingectomy, or it may be if the tube cannot be removed because of the condition of the other tube, the next surgery is salpingotomy. Salpingotomy, of course, in all these cases, the patient's condition is poor, so patient should permit. So salpingotomy, that means tube is preserved. Product removed, incision not closed. So over the picture I can, this is, you see, here is the clamp on the part and another clamp in this area. That is your infundibulo, not infundibulopelvic, but it is mesosalpinx. The mesosalpinx, and here is the at the corner. So this is salpingectomy, containing ectopic mass is removed. So total salpingectomy, that means entire tumor is removed. Or you can do, if you like, that the partial salpingectomy. That means the affected part of the tube is removed and medial and lateral end is kept. Later on, you can go for anastomosing of the tube. Tube may be rejoined later to preserve fertility. So that is the surgery which is done. So this can be done by laparotomy or by laparoscopy, both. And less than 2 centimeter of ectopic. So salpingotomy cannot be done always. So ectopic mass should be less than 2 centimeter and milking of the tube. So tube is expressed and the product is removed. Product is removed. That is milking of the tube. That has been shown. You see, this is laparoscopy done likely. So laparoscopic, this is the original picture, but this is the schematic. You see, there is the ectopic, and by a monopolar cautery you are putting incision there. And this ectopic, the pregnancy sac is taken by the forceps. And so after that, this will be the appearance. So you leave the tube like that, and within few days, this will be united. So if you give a suture here, there will be stricture there. So there is chance of more ectopic. So to avoid that, we leave the tube open and it will be united later on. And though whenever you are preserving the tube, so there is always chance of ectopic at that site. So that is there. With that risk, there is no other way than to, if you remove this tube, so patient will have no option to go further pregnancy. That's why conservative surgery is done. So then is medical. So that is surgical, then comes medical. So medical for the ectopic pregnancy has certain criteria. In all the cases are not fit for medical treatment, because if the patient is in acute state, so you have to do the surgery. If the patient is having the larger mass, so medical treatment may not be successful because amount of trophoblastic tissue which is present, that is a consideration for medical treatment. If it is mass is more, so methotrexate will not be able to work. So in that case, surgery has to be done. So serum HCG, which we are talking, that for planning medical treatment, for planning of medical treatment, serum HCG estimation is to be done. So it must be less than 3000 unit. Somehow it is written less than 2000 unit. So to have more successful, if the amount is less, the more will be the medical treatment will be successful. Mass must be 3.5 centimeter or less. Mass, tubal mass must be 3.5 centimeter or less. Hemodynamically stable. Injection methotrexate is given IM, not the oral, per square meter, and estimation of serum beta HCG weekly till it is less than 20 international unit. But risk of medical treatment is rupture. So medical treatment, you cannot allow the patient to take the injection and go at home and sit there. You have to keep the patient at the hospital and go on doing medical treatment. So anytime if there is rupture, you can take the patient to the OT and immediately you can do the surgeries. And so if it does not respond, that means weekly beta HCG estimation you are doing. If it fails to show the reduction of HCG less than 15%, then consecutively you can give 3 or 4 injections. After that, if it is not declining, that means you have to declare that failure of medical treatment. So otherwise, if after single injection, if beta HCG goes on falling, so you have to do only the estimation, not the repeat injections. Repeat injection will be needed if it shows less than 15% fall by 7 days. So that is about the criteria and medical treatment. Of course, methotrexate is a toxic drug, you know, that will be discussed with the patient. Alopecia and so many complications in the epithelial may be there, ulceration. So that is about medical treatment. And expectant is must be hemodynamically stable. And where you are doing expectant, where beta HCG is less than 1000. Less than 1000 means trophoblastic activity is very, very low. Expected it will go further low. That means fetus is dead, trophoblasty is also going down, and no collection or minimal collection less than 100 cc like that. Less collection in POD, that means it is not much disturbed, and already the tubal mole is there, already the pregnancy is dead. In that case, without intervention, without toxic medical treatment, you can wait for some time, of course not at home, at the hospital, and if it shows further declining with HCG, then you can rely on that it will be, there will be resolution, no further treatment will be given. So continuous resolution will occur. With that expectation, you can do the expectant treatment. And so abdominal pregnancy, few words. This is secondary to tubal abortion, tubal rupture, if the conceptus or embryo is live, and then it can reach the term, rarely, usually presented with IUD and malpresentation. Rarely may reach time. IUD and malpresentation is the usual presentation, and pain abdomen. So pain abdomen will be there always, because fetus is within the abdomen, with the movement of the fetus and because of the surrounding reaction of the trophoblastic tissue, pain abdomen will be there. And malpresentation, because it is not in the uterus, so in any direction it may lie, and rarely may reach term. Laparotomy as soon as detected, because if there is separation of the placenta at any time, patient will die at the midnight. So laparotomy as soon as it is detected, we will not allow the abdominal pregnancy to grow and reach the term. There is risk of maternal death. So placenta removal is a very big problem, because it may be attached to the liver. it may be attached to the spleen, it may be attached to the intestine. So you have to dissect all those areas. So, or if you try to separate it, there will be so much hemorrhage, so much that the patient will die on the OT table. So, very much careful if the abdominal pregnancy is diagnosed. If the abdominal pregnancy is not diagnosed, you have incidentally opened the abdomen and have pulled the placenta, then you will not be able to save the patient. So, placenta removal will be very, very cautious, or you cannot remove the placenta, you just keep the placenta inside and give the methotrexate for resolution of the deformostic tissues. Though they are associated, this is associated with complications of infection, peritonitis like that, but that is also a treatment, because otherwise there is no other way to treat the abdominal pregnancy. And always one thing is to be kept in mind, if the abdominal pregnancy is diagnosed, we ask the surgeons to keep at our side. So anytime there is brisk bleeding, so surgeon is there, he will be able likely to tackle the bleeding from the mesenteric bed or from the other muscular beds, even in the bladder. So this is about abdominal pregnancy. I have seen one patient to die even with the surgeon beside the patient. So pregnancy diagnosed, surgeon was called before operation, but still we cannot save that patient. So always you have to counsel the patient if you have diagnosed abdominal pregnancy, there may be death of the patient. Scar pregnancy, that is at the site of the uterine scar, because the myometrium is deficient, it can easily rupture, presented as rupture of the scar, bleeding PV, detected by USG on the anterior wall of the uterus. Repair of the uterine wall can be done, or maybe hysterectomy may be needed if the bleeding cannot be controlled. So that is about the scar pregnancy. Heterotopic pregnancy, this is another entity, though very rare. That means coexistence of intrauterine pregnancy with ectopic pregnancy. So that is very rare. How that happens is a very so rare. And salpingectomy is to be done in cases of ectopic pregnancy. Salpingectomy done, but intrauterine pregnancy could be continued, because the pregnancy is early, so it may not be disturbed because of laparotomy, and methotrexate should not be given because you are continuing the intrauterine pregnancy. So for the extrauterine pregnancy, methotrexate should not be given. The summary, cause of maternal death. So this is very important of ectopic pregnancy. That's why we study the subject, because it could cause maternal death if you are not ectopic minded, and so many deaths. Last time there was a very big publication in the Anandabazar Patrika, that death possibly occurs in the National Medical College. The ectopic pregnancy was admitted without undiagnosed in the Department of Surgery. Then it was referred to the gynecologist, and when the abdomen was opened, after that the problem could not be tackled, so there was maternal death. So USG can exclude intrauterine pregnancy. In that case, ectopic pregnancy should always be considered. So laparotomy and blood transfusion is life-saving. So always blood and blood. Always, even you can, if the patient is in a very very critical condition, because if you keep the patient like that, patient may die. So even if you have to do the laparotomy, just to stop the bleeding, you have to open the abdomen and put a clamp with the risk of death, but blood transfusion should be arranged quickly. If you cannot arrange blood transfusion, patient may die. So even before the blood transfusion is available, you have to go for laparotomy, you have to open the abdomen, because leaving the patient as such will not improve the condition of the patient. Laparoscopy is for both diagnosis and treatment. So very, very important laparoscopy, role of laparoscope. Now that's all.